Hey, so today we had a webinar that was actually more of a grand rounds that we were presenting a case and we were talking about sort of treatment protocols all surrounding heartburn and GERD. So if you don't know this already, there is a class of medications called proton pump inhibitors, and proton pump inhibitors are like the devil, I'm gonna call them. I mean, at one level, they could be life-saving for someone with a GI bleed or someone that has severe erosion of the esophagus and protecting the esophagus, but like normally there's a reason why they're having severe erosion, and no standard of medical process is actually addressing that, except for there is a standard of care to check for H. pylori, and if that's positive through a urea breath test or some kind of test, other types of testing during a endoscopy, treatment for that could be also, utilized in helping people to, heal and get rid of the gastritis, which is that inflammation in the stomach and all of those things. But traditionally, that type of testing isn't always the best, and there's other ways that we can look for H. pylori, particularly with a PCR test in the stool that's actually probably going to result more often or show us that quantitative level that's there for the H. pylori. So working with a functional medicine practitioner, or if you're a clinician listening to this and you're like, hey, oh my goodness, I want to learn more about how to help patients get off PPIs, I'll put the link to our webinar registration page. The webinar is over, but you'll get the replay when you tap that once we get that sent out. But what I would like to talk about is like, what are the key things about getting off a PPI? So if you're on a PPI, it is doing more harm than good, unless you're in that category of you have erosive esophagitis, so inflammation of the esophagus, or you have an ulcer, or you have Barrett's esophagus. So any of those categories, you're going to work with your GI specialist. You're going to make sure that, it's okay to come off. Obviously, anytime you're going to work with your provider and make sure we're just giving general general education here. But if you are not in that category and there's no significant risk to you by not being on it, like the risk likely is more that you're continuing it just for general GERD, which is that acid coming up, the heartburn, those types of symptoms. I've had patients in my career that I mentioned this on the webinar, that I looked in their chart and I was like, why are you taking this? There's no mention of heartburn in here at all. You ask the patient, I don't know, I don't have heartburn, I just got this. So they go to the ER, they have nausea, they get put on a PPI, and it just gets continued. Or they're in a significant situation where they're in the ICU and they're put on it for stress ulcer prophylaxis, which can be life-saving in that moment. But when you leave the hospital and the years after that, you don't need to be taking this. So my one patient was probably taking this for 7 to 10 years before I realized that you're on this for no reason. And, it takes really just that's really why pharmacists are, awesome in family medicine, because like a family medicine counter is 11 minutes in most places, maybe less. And so in that case, like the doctor doesn't have time to dig through the chart and figure out why in the world someone's taking this. They're just making sure they're stable, refilling the medications the patient needs. And sometimes they just don't have time to dig into that. And that's a system-wide problem, not an individual practitioner problem. But if we are taking PPIs for too long, it decreases our stomach acid, which shifts how we can actually absorb nutrients. So you're not going to absorb your iron as much. You're not going to absorb calcium, magnesium, other minerals. So then we get to the point where people have fatigue. Maybe they even have brain fog. Maybe they're not absorbing their B vitamins appropriately. And so that all goes into that energy cascade, and we need all of those nutrients, iron, all of it, for creating energy in our Krebs cycle and our mitochondrial function. But it also has been linked to increased risk of stroke and cardiovascular disease for long-term use of PPIs. Mechanism of that, I'm not exactly sure if it's related to, and I don't know that we know, if it's related to the nutrient depletions or if it's related to the microbiome changes potentially going on there, or if it's just connected because of this patient population. I think we're still trying to learn what is that. But we do know that decrease in calcium absorption and our minerals is linked to increased risk of osteoporosis. So if you're just taking this class of medications because someone told you to take it for heartburn, we really need to figure out what your plan is to coming off of it. So from a functional medicine perspective, our plan for coming off of it is a couple different things. So we're going to assess the microbiome and figure out what in the heck's going on in there that's contributing to this potential inflammation and potential excess acid secretion, if that is the concern. Sometimes it's actually a lack of acid, and people actually feel better taking something like betaine hydrochloric acid by helping them digest their food and starting that process better. But whatever it is, we need to figure out what is the root cause. And there's also other providers that can be great allies in this piece. So people that are physical manipulation, I love sending patients to osteopaths. So like going to a DO provider that does manipulation, or a chiropractor, or even acupuncture has data and help for just calming that central nervous system response that is responsible for stress and contributing to this. So there's lots of lifestyle things also. I mean, eating different diet, not eating as much caffeine or acidic foods, like all of those things. But particularly some nutrients that we talked about today in the webinar I thought were interesting. So you've probably heard a lot about DGL, which is deglycerinized licorice. And so it takes out the part that really increases your risk for high blood pressure, but it still has the properties that help it to soothe the intestinal lining. And so we really like using that in our protocols. And so it can be anti-allergenic, antimicrobial, anti-inflammatory, but has data in this population for functional dyspepsia. So definitely having something with DGL on board. And then zinc carnosine is in a lot of products that are focused at heartburn. And that is a version of zinc that has cytokine modulation, so help calming down that overactive immune response, stabilizing the membranes, and then also has some data in the treatment and management of peptic ulcers or oral mucositis and esophagitis from chemoradiation type therapies. So it really helps to promote like mucosal injury. So a lot of times that is used alongside DGL, alongside maybe some other nutrients, including aloe vera. Aloe vera is also really good for, it has over 75 different compounds in it that are helping to they're protective of the cells. They're anti-inflammatory, anti-ulcerative benefits, wound healing properties. And so it can be a strong laxative though. So if you are already having problems with having loose stools, then you definitely don't want to do too much aloe vera. But the one that I was like surprised about and is new information to me, and I think I'd seen this before a little bit, some in the like athletic nutrition data, was using melatonin though in patients that are trying to get off PPIs. So a major function of locally produced melatonin in the GI tract is actually to strengthen the esophageal and gastric mucosal barrier. So in layman's terms, it's helping to make your esophagus stronger and the mucosal barrier that protects your cells, stomach cells from the acid in the stomach. It's strengthening that. And so it also just has this protective effect where it helps to sort of clean up reactive oxygen species, which are those inflammation pieces, and has a role in like secretion of acid and helping digestion and motility. So it's super interesting, and there's actual data on sort of a combination of supplements. So there was one group of people, they had GERD symptoms, and one group got a formulation of 6 milligrams of melatonin with tryptophan and vitamin B12. I'll highlight this as well. Methionine, which some of the products have methylmethionine in it that we use, particularly in this protocol from Designs for Health and GastroMend, but that is, we call it vitamin U, but it is a component of cabbage. So you can drink like raw, like there's data showing raw cabbage juice helps cure ulcers, but how many patients are going to drink that many cups of raw cabbage juice per day? So it's a little easier just to swallow a capsule. But it had folic acid in it. It had some of the betaine hydrochloric acid. And then they compared that group to the group that was taking omeprazole 40 milligrams. So the group A, which took the supplement blend with the melatonin, 100% regression of their symptoms versus 65% regression in the group B. And so I just think that goes to show like we're fixing like the problem. And I also think the connection between the circadian rhythm component and melatonin and all of that is super interesting when it comes to GERD and even probably vagal nerve like stimulation. So super interesting. There, if you go and look in PubMed for GERD and melatonin, like there's a lot of things in this functional dyspepsia and all of those things. So that's my clinical pro for today is consider melatonin in your treatment plans when you're trying to get patients off of PPIs. And really just like, you can't just stop the PPI and stop it right away. You have to slowly come down on the PPI. So if someone's on 40 milligrams of omeprazole twice a day, I'm normally stepping down to 40 once a day. Then I'm maybe doing every other day, or getting them 20 at that point, 20 a day, which is over the counter. And then we're doing like an every other day. But we're also coming alongside that with all of these interventions. So assessing the microbiome, if we have bugs, pathogens, yeast. Yeast is a huge trigger for GERD, which I didn't even mention. I've mentioned that probably other times on here as well. But treating the yeast is really important alongside any other pathogens that might come up. And then those gut healing nutrients are so important, especially if there's any gastritis or irritation. And then, helping them, certain probiotic strains inhibit or have data to show they improve GERD symptoms and heartburn symptoms. So there's a lot of world of this, but people need to come off this. We're creating a nightmare when it comes to osteoporosis. And we already have so much cardiovascular risk in the United States. Like, we can't add another thing that is worsening this. So I challenge you, if you are in family medicine, if you are in primary care, even if you're in GI, pharmacist in the pharmacy, like, ask your patient when they come in the door, they sit down and you say, why are you taking on this omeprazole? How long have you been taking this omeprazole? If they're in your pharmacy, tag it. If you see it as something that's long-term, like, hey, like, do you know the dangers to taking this long-term? Have you ever talked to your provider? Have they ever said the words Barrett's esophagus, or do you have an ulcer? Like, learn more about why your patient is taking this, because you could change their life. You can change your life every day with things that you do, but this is a huge thing that you can make a difference in the trajectory. There's increased risk for SIBO, all of the things if we continue to take the PPI. So if this your one little tiny mission in your healthcare practice is to try to get people off PPIs, I will be your biggest cheerleader.